Incredible Master of Arts in Maternal Child Health Systems candidate, Andrea Ferroni, and her presentation.
Am I here? Okay. Hi, I'm Andrea Ferroni. This is the name of my presentation, Why the Gap When There's an App. And my project is about dentists and their prescribing practices towards lactating patients. I'm a midwife primarily. I've also been in healthcare administration. I know nothing about dentists. I do now. I didn't know anything about dentists or dentistry or prescribing before doing this project. And to be honest, I came late to this program, and within 5 minutes of the first day I was asked to pick something, so I picked this. I am fierce about helping people who want to nurse as long as they can. And that's why I chose this project. So as a midwife, when somebody asks me if they can take a medication while they're nursing, I pull out my phone and I look it up, and it takes me about 15 seconds. And then I read to them what the app that I look at says. I also field a lot of panicked phone calls, primarily from my clients, but also family and friends, when they have gotten done with a dentist appointment and they're told when they leave that they need to take a medication. It's usually something pretty benign, like an antibiotic, and the dentist has told them that they need to stop nursing. So stop nursing, even for a short time, is not an option in my book for people who still want to nurse. It's a really big deal to say this to a nursing parent. And for some people, it can really sabotage something they've worked hard to establish, and it can even end the nursing relationship. So I would hang up from these phone calls and I would be really frustrated, and I would ask myself, why would they say that? Why would they say that about amoxicillin? And really my why was a pretty thinly veiled, what is wrong with you? What is wrong with you as a provider that you would do this? So my hypothesis was that they just didn't know, that they were too lazy to look it up, and they wouldn't say that they didn't know, and that they didn't care about nursing to spend a couple of seconds. It was just easiest for them to say, don't nurse. So this project is more my inquiry, instead of what's wrong with you, but really asking, why would a prescriber do that? What's in play that a prescriber would tell somebody to not nurse rather than to know that amoxicillin is fine? So I'll be getting into the factors that intersect that lead a prescriber to do that. So if you saw Trinity's presentation before me, she covered this beautifully, that the language that I'm using, I'll be using the terms nursing and breast chest feeding to describe the act of feeding one's baby from one's body. And I mean this language to affirm the experiences of women who nurse their babies and of masculine identified trans people who feed their babies from their bodies. With the research and the dentists that I interviewed often use the terms woman and breastfeeding, and I'll retain their language throughout for consistency. For me, and for people who've been around nursing, maybe for you too, there's a real sweetness in the terms that babies themselves come up with for this, like nons or teta, and my own kids who tandem nursed and would fight, what they would call my own anatomy was the nurse babies, as in, that's my nurse baby, that's your nurse baby. Again, I thank Trinity for covering this beautifully earlier in the day, but human milk is miraculous, and the evidence for it is absolutely overwhelming. Every national and global organization is unanimous in promoting exclusive nursing up till 6 months, and for continued supplementary nursing through 1 year and beyond 1 year with no prescribed end time. This, another organization, both organizations, dental associations, also recommend this, the American Dental Association and the American Academy of Pediatric Dentists. The ADA says that children exclusively nursed to 6 months are less likely to have alignment issues with their teeth and jaw than formula-fed babies. And though nursing past 1 year has many benefits, lactation at this stage is pretty uncommon. only a third of babies are still getting any milk at 1 year, and by 18 months, that drops to less than 15%. Dr. Jack Newman is a Canadian pediatrician and a breastfeeding advocate, and he hears from his patients that even when the people that he works with at his clinic, that even when everything is going really well, doctors will often tell mothers to stop breastfeeding because there's no further benefits to the baby. The people in my life who were told to stop nursing to take a medication were usually nursing toddlers. The Surgeon General in 2011 said that all healthcare professionals that interact with a nursing couple impact their success, and that all healthcare professionals must provide anticipatory guidance and conscientiously remove barriers to success, such as misinformation, inappropriate advice, and uncoordinated care. Trinity also addressed this beautifully and deeper than I will, but populations that are hammered by systemic oppression and historic injustice especially don't need further hurdles to successful lactation. Racial inequities impact every single facet of health, including breast and chest feeding rates and including oral health. Healthy People 2030 dental objectives call this out explicitly. And in their objectives, they say that dental schools need to scale up their curriculum to address population health. So my project, here is what I intended to do. I thought I would review the curriculum and all the materials that dentists get passively and purposefully to understand how they're taught on this topic. I thought I'd be able to lurk on some forums and blogs to see how they talk to each other about it. And I'd hope to get a couple of expert dentists to inform my project, but also just help me formulate my inquiry and my interview questions. I learned pretty early on with my exploratory literature searches that there isn't much literature about this. And so originally I was going to do a survey, and I changed that to be an interview to do qualitative research and interview them because of the lack of literature. So here's kind of what ended up happening. That was my goal, and here's how it ended up. To my surprise, and also I didn't have a lot of access, there's just really not much there. The American Dental Association has a Center for Evidence-Based Dentistry, and I thought that's where I'm going to find everything, but there's no guidelines about this. Their guidelines around this population are more about oral health and pregnancy, or about materials for dentists who are caring for nursing babies. I didn't find any blogs or forums. I wrote to 6 different dental schools from all across the country, and I didn't hear anything back. I was getting desperate. I actually made an appointment with my own dentist to get my teeth cleaned so that I could have access to a dentist to be able to ask questions, because I really had no idea if dentists prescribe 100 medications or 10 medications, and I just needed to have some foundation to start my interview guide. So as I mentioned, the literature is scant. I did a search on PubMed and Embase and Scopus, and my search with these keywords that you see here resulted in less than 30 articles. And then when I would dive into the articles, again, they would be about pregnancy. Even though they said pregnancy and lactation, it would be about pregnancy. So not trusting my own findings, I hand searched some lactation and dental journals. And to the best of my knowledge in the United States, there really is no literature that specifically addresses dentists' knowledge, attitude, practices, and barriers prescribing to this patient population. I'd also hoped to interview 15 to 20 dentists. I ended up with 6, and a practice friend that was actually really fruitful with a physician assistant friend of mine. So that was also a less than desired result. So there's so much in my literature review, but I'm just going to briefly touch on some of the findings. And in a moment, I'll expand upon where I think the biggest disconnects are happening. So I would just say broadly, and we know this, but dentists are clinicians and clinicians are people first. They're coming to practice with all of the socialization and cultural assumptions and biases to the patient encounter from their life. So this, of course, includes lactation. There's research that demonstrates that practitioner attitudes towards extended nursing specifically are negative, and that the attitudes are more and more negative the older the baby gets. There's also research that shows that a provider's personal lactation experience is the factor that is most associated with how they educate their patients, which can really go either way. Though research shows that healthcare provider status seems to boost lactation success rates over that of the general population, it shows that even physician mothers don't meet their own initial goals for breastfeeding. Their rates are better than the national average, but they're still not great. So my study then is based largely on the literature and on the interviews that I conducted with dentists. The majority of articles in the literature about prescribing to a lactation population have doctors as the provider of interest. So my interview questions riffed off of the core themes that was identified in the literature, imagining that dentists might be similar. So my interview guide had 14 questions with a bunch of follow-up questions that were designed to solicit responses broadly about dentists' personal and professional relationship or experiences with nursing, their clinical approach to lactating patients, their decision-making around prescribing, what they know about national and international recommendations, what they know about the benefits of human milk, their perceptions of safety, risk, responsibility, and what resources they're accessing. Here's just 5 of my questions. These were the ones that didn't, a lot of my questions shifted. These were ones that didn't shift very much as I was speaking to dentists. Most of the participants in my study had practiced between 10 and 20 years. One was freshly graduated and another had been practicing for more than 40 years. Most of them were in group practice in Northern California, where I am. I used a snowball study, which I think skewed them to Northern California. 5 were white, 1 was Black, 3 were women and 3 were men. 3 were parents and 1 was pregnant with her first. All of the parents had children who nursed according to what the AAP recommendations were at the time, including the dentist who'd been practicing for 40 years. And the one that was pregnant was planning to nurse and was pretty excited about it. So towards the end of my literature review, I came across this, which is on the ADA's, it has a blog for parents, a consumer-facing blog called Mouth Healthy. So I know some people read and some people want to be told, so I'll give you a minute to take it in. But this post is called Breastfeeding: 6 Things Nursing Moms Should Know About Dental Health. So it starts out very reassuring about it's fine, it's fine, it's fine. You can probably take medication, but like, let's just sit with this advice. The ADA is telling us that after our licensed dentist, a prescriber, prescribes us something to treat us, that we should continue to vet this medication with 2 more clinicians. And then we should go to research it on our own. And then we're supposed to circle back to our doctor with what we found when we were researching this medication, including our own suggestions for alternative medications and what we learned about how it impacts our milk supply. So I haven't had a lot of prescriptions in my life, but this seems crazy to me. This seems like a real atypical absence of authoritative guidance and education on the part of the prescriber. It also puts extraordinary financial and cognitive responsibility on the patient who might just need to treat a tooth abscess. So I was surprised and saddened during my interviews that this ADA website is pretty representative of how the dentists in my study thought about primary responsibility for checking a medication suitability for babies with lactating patients. So with the exception of the quote on top, that was the only dentist in my study who claimed full responsibility for vetting the medication. Everyone else had a real diffuse approach to prescribing, and they also didn't really land on who they should be consulting with. OBs were mentioned, the PCP, some of them had the benefit of working in FQHCs or group practice. They would check with the physicians there. One, I think she's there in the, middle, or maybe, anyway, no, the first one, relied on the patients themselves, said my patients come in seeming to already know. I trust that they know. Um, I I understood from talking to the dentist that they thought all of this checking with everybody else was really intended to reassure both themselves and the patients. But to me, it really sends the message to the patients that the dentist is not confident at all that the medication that they're prescribing is safe for the baby. So there's a couple of areas that really intersect to muddle prescribing, really for any prescriber, but also for dentists. And this is a huge one, and it seems very, very simple, but it's really, really entrenched. Lactation is not pregnancy, but they're absolutely conflated in the literature, in the educational resources, and in all of the guides. Not all of them, most of the guides that most of the resources that guide prescribing, and they're super conflated in the minds of clinicians. It's like there is a condition called pregnancy breastfeeding. It was glaring in my study. All but one dentist substituted pregnancy when I asked about lactation, and most of them did it every single time in response to every single question. For example, a dentist said to me, I don't have such a high volume of pregnant breastfeeding patients. I look up the pregnancy breastfeeding category before I prescribe, and I don't think I've ever prescribed Ativan to a pregnant breastfeeding patient. So this is problematic because it confuses the management of lactating patients in two critical ways. First, pregnancy risk to the fetus does not correlate to risk to a born and nursing baby, period. They're different systems. But the pregnancy risk, which is often higher than the lactation risk, sticks in the minds of clinicians, influencing them to overestimate a medication's risk during lactation. That quote that I just said to you was from an oral surgeon who believed that Versed, which is used in many of her procedures, and it's contraindicated in every trimester in pregnancy. She believed that she couldn't use it during lactation when in fact it requires little to no modification of nursing behavior. Second, conflating pregnancy and lactation makes dentists think of the wrong physician for consultation. They are often looking to OBs, who are fetus doctors, when the clinician best suited to determine the risk of a medication to a baby or anticipate potential side effects is a provider whose primary scope is babies, right? A pediatric care provider. Dentists and other prescribers would really benefit from detaching pregnancy and lactation in their minds when they're considering a medication's risk. Lactation is not a subset of pregnancy, but it's treated so pretty much everywhere. This confusion hasn't been helped by the FDA's ABCDX safety rating system for pregnancy and lactation that it put in place in 1979. It's really it was set up as a green light, red light, safe, toxic, pretty binary system. And it was criticized for being imprecise, for not showing the data that informed those ratings, and therefore rendering a risk-benefit analysis impossible. So in 2015, it was replaced with the Pregnancy and Lactation Labeling Rule, the PLLR, which on purpose explicitly promoted a benefit versus risk approach. So any drug that's absorbed systemically must include a narrative summary describing what the most current research reveals about its use in lactation, a review that synopsizes the human and animal studies, and a risk-benefit statement, which sounds something like limited information indicates this produces low levels in milk that are not expected to cause adverse effects in breastfed infants. The PLLR has some other requirements. It requires disclosing the presence and the amount of the drug in human milk, the side effects to the child, and pretty importantly, the impact on milk production. So 6 years after implementing this PLLR format, the clarity that the FDA sought for prescribers is just not happening. references to this retired labeling schema and the conflation of pregnancy and lactation is pretty alive and well in published materials, including within the ADA's own recently 2019 published drug prescribing quick reference guide. Not one of the dentists in my study were aware of this labeling rule, and most of the dentists throughout the interviews referred to this ABCDX system or the pregnancy categories repeatedly when they were discussing safety data. So these, LactMed and the Infant Risk Center and apps, these are the credible lactation-specific resources that do format the drug summaries according to the PLLR. Not a single dentist in the study were aware of them, and dental schools and dental organizations aren't orienting dentists to them. When I asked the dentists what resources they consult with before prescribing, few of them had any overlapping resources. None of them were lactation specific, and many of them were ones that the literature said are not great. And the dentist reported a lot of Googling. Because I wasn't able to review curriculum, I have to infer about how dental schools teach the clinical management of lactating patients from this very small sample of dentists that I interviewed. But 4 recalled that it was absolutely absent, and 2 thought it was covered, but the way that it was covered was not useful. What's clear to me is that these dentists and clinicians in the literature don't have a standardized approach to managing a lactating population. None of the dentists in the study had a routine way to determine lactation status at the time of the encounter. And they mostly learned it passively, and they all learned it differently. So maybe the patient would volunteer it when the treatment indicated that a medication would be needed. Sometimes the dentist said they would just know, or that the dental assistants would tell them, or that they would remember that the patient had been pregnant, or they would physically see the patient and a baby nursing waiting for the encounter. Most of the dentists, as they were answering this question, they were hearing themselves say out loud that they don't routinely ask, and you could see it dawn on them that that was a problem. One dentist said his answer was, the realistic answer, it's probably by accident. And a better answer would be that I would probably ask. But do I ask now? I should, probably. I mean, this conversation is helping me learn a little bit. So all of the medications that dentists in this study use are fine, or they're mostly fine during lactation. The literature said that prescribers overestimate risk, and dentists in this study were knowledgeable about most of the medications they use, and they did overestimate the risk, specifically of prescription strength pain medication and drugs for anxiety. The 2 dentists who do conscious sedation believe that the conscious sedation drugs were absolutely contraindicated during lactation, but they are fine. The literature also reported that prescribers don't engage in shared decision-making with lactating patients. And I thought I knew what that looked like, especially based on my experience in my town. But how it showed up in the interviews wasn't that the dentists told patients to stop nursing. What it looked like is that they would backpedal when the patient was anxious about taking a medication. And then they would meet the patient's caution with vague suggestions to maybe nurse less or maybe delay nursing, not in any way based on the drug's LactMed summary. One dentist said, I would tell an anxious patient maybe just wait to either pump or breastfeed for an hour or so, just if you're concerned about anything being passed to your child. Another said, I say, we're going to give you an anesthetic and the amount going into breast milk is minimal, but you may want to discard that first pump after the procedure. So instead of offering this vague postponement of nursing that's unneeded, the dentist could serve the patients a lot better by just standing in their authority as the prescriber and talking the patient through the medication's profile rather than mirroring their anxiety back at them. For instance, a patient who needs a procedure with conscious sedation could just be told what the LactMed summary says, which is that small amounts aren't expected to cause any adverse effects in most infants, but there are 2 expert panels who recommend waiting for 4 hours before nursing. With true informed consent, the dentist could also highlight that in one of those studies, milk output was decreased by half after the procedure. And then that would enable the patient to bank some milk in case they are to experience that side effect. That's shared decision making. So overall, this study and these dentists, all 6 of them, left me feeling pretty hopeful. They were really natural allies. They just needed it brought to their attention. And in contrast to clinicians in the literature, the dentist I interviewed had 0 bias against lactation. The 3 who had children had nursed their children to and beyond the national recommendations. And whether they were parents or not, they were all very effortlessly and easily able to rattle off all of the benefits to both the baby and parent, dentist specific and not. While we were talking, they really connected a lot of the dots for themselves, like realizing that if a medication is safe for a baby, that it's probably fine during lactation. And they really noticed where their own unexamined practices, such as not determining lactation status routinely, present as barriers to optimal management of this population. And they were pretty quick to acknowledge that overcaution and inadequate knowledge leads their patients to receiving less routine care and fewer procedures, which can negatively impact their health. So while we were talking, the dentist also provided impromptu recommendations for amending their current practices. And most of them asked me to circle back around to them and their profession with this information. So what I would like to see happen is the reshaping of curriculum to incorporate clinical management of the lactating patient as its own thing, distinct and disentangled from pregnancy. This would be a separate lactation module, ideally in dental school, but it could also be in continuing education. It could be in the journals, staff meetings, webinars. There's really not that many pieces to it, and it's pretty simple. The first part is just screen and build it into the patient assessment. Dental staff shouldn't be gleaning this somehow. And dentists really need to be empowered to take responsibility as prescribers. Just be the prescriber. Learn the drugs, and most of them already know the profiles of the drugs. Use infant risk and LactMed, and reassure patients, don't mirror their anxiety, educate them in the spirit of the PLLR, and let them make their own decisions for themselves based on what the data says about that drug. Don't tell people to pump. It's not a nothing intervention, in particular when people have never done it and they don't know how and they don't own the stuff. Only modify nursing schedules based on the drug's profile. And then if you're going to make that recommendation, you have to get them you either have to educate them on how to do that, or you have to make a referral to somebody like Leche League or WIC who can help them through that. And that it's really that simple. This one dentist quote that I put here, said something like, take the, what'd you say? Take the load off of us. They were really kind of fraught and thinking that it was this big mysterious zone that they were potentially harming people. And it's really, really simple. Their values are really aligned, but they're just not confident. This isn't lengthy and it's not hard. I feel like you could teach it in whatever I'm doing right now, 30 minutes. It just needs to be brought as its own competency and not squeezed in as a special case or smashed in there with pregnancy, like pregnancy part B. So closing the gap, it seems pretty achievable to me. What dentists, and I don't know anything about other prescribers, but it seems to me what they really have going for them is they use 10 medications tops. Half of them are antibiotics, which is fine, and the rest are also kind of fine. There's they can memorize it, and what they can't memorize, they can look it up pretty easily on Infant Risk and LactMed once they know that those resources exist. These dentists who are currently contributing to overestimation of medication risk and unclear advice can really quite easily become a source of clear guidance and align their support with breastfeeding, what they state and what they did in their own families with their clinical practice. So strengths of this study is that, to the best of my knowledge, this is the only study in the US that explores the topic of clinical management of or prescribing specifically in dentist attitude, knowledge, and practices with dentists. And the themes emerged pretty quickly and were in line with the literature. I would say a strength of this is it just seems like such an easy repair, and the dentists I interviewed were really, really behind it. This study originally, I think, benefited from me also being a clinician and being kind of a small town community midwife, because I know people forever. So I receive their calls when they're nursing a 2-year-old. So I was able to recognize this from my position as a community midwife. But then even within the interviews, I think it helped that I was a clinician, because I had a kind of a nice rapport with the dentist. I understand clinical decision making. I get how time crunched they are in their encounters. And I know from my own clinical practice that when something seems like a kind of a tiny subject, even if you're interested in it, you don't necessarily get to it like you want to. A lot of us often have a really long to-do list of things we wish we knew better, and we're doing better. I really loved interviewing these dentists. I was so surprised about it. I don't know. So I did ask them to share their nursing experiences, but I didn't ask them to share their pregnancy and birth experiences, which they did, which really humanized them to me. They shared stories about their own anxiety, even as dentists, as prescribers, when they were taking medication, when they were nursing. They shared stories about how irritated they were when they were pregnant, that practitioners wouldn't touch them with a 10-foot pole rather than just learning what they needed to do to take care of them. It was fun. So the most obvious limitation is that it was I only talked to 6 people with such a tiny sample. And I will say that every dentist that I talked to did kind of add their own little thing. So I think if I could have kept going, I may have learned some more. And that one dentist who was the lone dentist who took responsibility for prescribing was the last person I talked to. And had I not talked to her, I would have thought that none of them claim any responsibility. So I don't think I reached saturation with my sample, but I don't think I was far off. Another limitation is that the conclusions are really just drawn from the literature. It's missing curriculum samples. I hope somebody swoops in and plops a bunch of curriculum on my lap to show me how wrong I am. But so far, I don't know. It's also really hard to quantify how big of a problem this is. I don't know where it would be documented or who would be documenting it. And so to put in an intervention to repair it would be really hard to evaluate how impactful that intervention is. So the most obvious future research would be to do this study on a bigger scale to see if the findings are still consistent. But honestly, let's just do the intervention. Like, I feel like let's not waste a bunch of time learning what we already know, which is that this is happening even when dentists really perceive themselves as supporting of nursing. So yeah, let's just get out the curriculum and fix it. So these are the people who are just critical in helping me get through this project. There's a lot of veterans, but there's a lot of one-year wonders like Christina and Jen. Christina was invaluable for teaching our research design class and then really just stepping in mid-project to help me. Her mastery of research design, I just really couldn't have done any pieces of this. I remember thinking, like, I'm supposed to analyze this. I don't even know what that means. And she would send me a bunch of examples. So just the mastery of research design that she has, the economy and the precision of her feedback, and just the absolute stunning turnaround time of my drafts was incredible. And she's also very kind and encouraging. And really thanks to Karen and Nancy for starting this program, specifically as a practicing midwife. Thank you for raising the bar for midwives and research and really asking us to level up and join that conversation. Karen specifically for talking me down off of many ledges and reminding me to save something for my PhD. To Jen also for her impeccable feedback and helping me rekindle my affection for this topic when I was pretty sure that it was the stupidest thing and nobody needed to spend any time learning about it, including me. To Ekaterini from the library, who is also is pretty astonishing with her accessibility. She's like a bot, but she's a real person that you can actually talk to really demystifying the whole process for me. And then my other advisory committee people, Jessica, who I've still never met, but her own master's thesis was really concise and was a model for my own. To Rachel, who is an old and dear friend of mine and have done been on so many learning paths with her, and this project really benefited from her research expertise and her feedback. For my clients, for staying in contact with me forever, so I know what happens after the first 6 weeks, and also these dentists who I'm actually really fond of, and of course to my cohort who are just really superstars. And I didn't get to pick them, though I picked this program, but I really can't imagine having been in this learning environment without them, because I've learned so much from them. So thank you to all of you. How do I get out of here?
Well, we'll give you a huge round of applause while you figure out how to hop out of there. Thank you so much, Andrea. There are not words adequate to state what it is to undertake an original research project in a 1-year time frame and to conduct interviews. And I know you had some less than ideal findings, but I'm so deeply impressed with your knowledge of this subject. You know more, I'm pretty sure, than any dentist maybe on the planet about prescribing and lactation and your contribution to this field. So thank you so much. Incredibly impressive work. And I'm happy to open it up to questions and comments.
I've got some comments here to share with you. Your cohort mate, Jody Lynn, has said, Andrea, this is incredible. I hope you will submit an abstract or proposal to speak at a dental conference. Yes, absolutely. And a comment from Dr. Nancy Anderson to say, I particularly appreciate the huge gap that you've pointed out. There is a big difference between shared decision-making and lack of confidence, i.e. provider ignorance. You have pointed this out, and I'm wondering about presenting to a dental school class and or a dental conference. We need this information.
Andrea, I have a question for you. Can you maybe talk a little bit about how you came to know about these resources, like what your education was, how you knew how to access LactMed or other apps like that to answer the questions of your clients when it's clear why the gap when there's an app, right? I'm just curious how you learned about those kind of things.
I mean, so for me, there wasn't an app, right? Because I was educated in pre-app midwifery, but researching the history of perinatal pharmacology was illuminating to me, because it kind of placed me in a time and a context that I didn't realize I was in. So So Dr. Thomas Hale, who is started the Infant Risk Center at the Texas something something University. When I was a student, the resource that we had was his Medications and Mother's Milk, which as a new student, I just bought it every year and just thinking, oh, here's the resource. But what I didn't realize is that when I was a student, that book had existed. It was in its 3rd edition. So it was brand new. And with Thomas Hale, the field was brand new. His first edition, I think it was in 1992 or 3, was the first edition, and it was because it was the beginning of the field. So when I sat with that and I thought, anybody who's, I mean, I guess people get educated at different ages, but anybody who is my age or anybody who's slightly older grew up as a clinician in a world without a resource, and they were just muddling through the PDR or whatever they use. So that made me have compassion for these prescribers, and it was really clear with the absolute variety and absolute lack of overlap from the things that they're using, as nobody has sort of said, here, use these, and the research backs that up too. There's an OB who is also a lactation consultant who writes some articles basically saying, like, stop using these terrible old things, use LacMed, use Infant Risk. And I can't remember when the Infant Risk app came out, but I do know that people don't seem to know about it. And when I was in primary care, none of the clinicians knew about it. And there's a hotline that I would say, like, you can call them up anytime, you can call them up anytime. And the Infant Risk, some of their recent goals is to reach out to providers. And as one of my advisory committee pointed out, they don't have dentists on their list. So there's a gap there too.
Thanks, Andrea. I have a couple of comments/questions from the chat for you. The first is a comment from Trinity that says, I'm amazed by you. Excited to see all of the great things you will do. I'll be sharing the app resource with the WIC team. No more flipping through medications and mother's milk that we still use to this day. And the other is a comment and question from Karen. Andrea, I've known my dentist for 35 years. 30 years ago, she converted one of her dental bays into her lactation room for the 2 babies she brought to work with her, which she showed me since she knows I'm a midwife. But I've never asked her about her prescribing knowledge. I'll ask her when I go in for a cleaning next week. What should be my first question?
Ask her if she ever uses any anti-anxiety medications or pain prescriptions more than ibuprofen, and then ask her if those are fine for lactation. And then if she doesn't know, just pull out your app. And then tell her to tell all her dentist friends. It's just right here in the app.
Karen says as a follow-up, got it, will do. Oh, I better get that app. Other questions? Yeah, Christina.
Hi, everyone. So first of all, Andrea, thank you so much for being so brave as to engage in this journey of doing original research. After, our research class was pretty comprehensive, but it was not very applied. So I acknowledge how brave you were to go on this journey with me and pivoting from initially wanting to do a survey to, embracing qualitative research. And I'm so happy you came to like it, because maybe you can continue doing that. I don't know. It's just a thought. My question to you would be, okay, I got it that you would have wanted to continue interviewing people. But apart from that, what is the one thing that you would have done differently?
I mean, I would have landed on it a lot earlier, and it was just my own inexperience. Because I think if I could have moved through the literature review, I just couldn't stop. I couldn't stop looking for research because I could not believe that there wasn't any. I wish I would have moved on quicker and started my interviews earlier. And then I didn't really go into this in my next steps or future research, but there's areas that are sort of more ripe for implementation of interventions. Like that last person that really gave me hope for dentists worked within FQHC. And the other dentists that worked within tribal health, like Javon was saying earlier, because it's interdisciplinary, they were more confident. They could build their knowledge off of the other providers there. One thing I didn't say to these dentists is like, you guys are consulting with, nurse practitioners, but they might not know anything either. I didn't get into that because though I am picking on dentists in here, anybody who's been working with nursing people for a long time knows that they get this junk advice everywhere from every kind of provider. So I know I'm picking on dentists, but I wish I could have been like more targeted or more varied in my participant sample, just for that reason, because I stumbled upon her late. And I do think, I stopped after a couple months, but I was cold emailing. I would pick a geographical area. I'd be like Chicago, or pick like, Monterey Bay, Salinas in California. I was trying to pick areas where I would find a really different patient population, thinking that I would, learn something different from those dentists, or they might have a different investment. And nobody wrote me back. So, I'm not answering your question very well.
You did. You actually answered my question. So you would have sort of shifted your project timeline to start interviewing earlier also, and maybe have contacted experts who could have helped you connect with people from other regions to recruit a more diverse sample.
I should tell a little tiny bit of a story there. Is I did have somebody who had contacted me as a midwife years before, and I kind of had her contact in my phone, and she was a dentist, and she did look at my interview guide. So I did have a couple people, and she had a lot of people have pretty incredible personal stories, and hers was that she had a child who passed at 2 years old, I guess, because for a variety of reasons, but also had a kidney condition. And as a dentist, she was on the so conservative side for any medication. So she was my one expert person, and she was very skewed by her own, as the research says, her own personal experience, kind of even more than her education or the resources.
But Andrea, to finish off, notwithstanding the fact that you had a small sample, I feel like your research shows us that you can develop actionable recommendations, even if you have a smaller scale study. So kudos to you for that. I really enjoyed working with you.
Thank you. Thank you so much.
Andrea, I have a comment in the chat from Amy Frazier. This is amazing. What a gift you've given to the birthing community.
Thank you.
I also have another comment in the chat from Joanna Davis, who says, we have a great dental school here in Richmond, Virginia, and I'd love to host you to bring it here. And she has left an email address that I will text to you in the chat. You've got your first engagement from this work. Way to go, Andrea.
I'm ready. And even, several of the dentists are like, just let me know when you want to come to a conference. Seriously, that one slide is all that needs to be in there. It's very, very simple. And that is what is lucky for dentists. I'm sure that's not true for nurse practitioners or whoever else, but for dentists, like, it's so discreet.
Amazing. Any other questions or comments? Andrea, congratulations. This is such a tremendous piece of work and such a gap you've highlighted. And such a seminal work to fill that gap. I mean, to be the first that walks through that. So congratulations to you. And I'm going to express my gratitude for Christina as well, because when Andrea was like, I think I'm going to do original research, I was like, I think that's above my pay grade. And I also had Christina as a resource, and I could not have supported Andrea in the same way had you not been at the helm of this with her. So thank you so much. That is the conclusion of the MCHS independent projects, and I'm honored to know all of you. I'm so proud of the work you produced. You really are an incredibly special cohort and group, and I'll take the one-hit wonder from you, Andrea, as long as it was with the four of you. So thank you so much. And with that, I will pass it over to Dr. Gordon.
Thank you, and congratulations to all of the MCHS graduates. This was the last hurdle. Congratulations, you did it. And I'll be really happy to see you walk across the stage tomorrow. We have two more presentations coming up from the Masters of Midwifery students. So we will hear first from Britt Zell, and that will be in about 9 minutes. So take a break, fill your water bottles, and we'll see you back in a few.
She works the nights by the water. She's gone astray, so far away from my father's daughter. She just wants a life for a baby. All I want, no one will come. She's got to save him. She tells him, oh, love, no one's ever gonna hurt you, love. I'm gonna give you what I'm on, love. Nobody matters like you. She tells him your life ain't gonna be nothing like my life. You're gonna go and have a good life. I'm gonna do what I got to say. So rock-a-bye, baby, rock-a-bye. I'm gonna rock you, rock-a-bye, baby, don't you cry. Somebody's got you, rock-a-bye, baby, rock-a-bye. I'm gonna rock you, rock-a-bye, baby, don't you cry.
Single mom, what you doing out there? Facing the hard life without a fear. I see I know that you really care. Cause when the obstacle come, you will prepare. No, mama, you never shed tear by you. I've been said things year after year. And who give me you love me and compare. To find the school fee and they must share. Already pops disappear. In a run bar, can't find it nowhere. Steadily your workflow, everything you know. So you don't stop, no time for your dear.
Now she got a 6-year-old, trying to keep him warm, trying to keep all the road. When he looks in